Hello, I'm Christopher Hirose. I'm a foot and ankle orthopedic specialist here at the Coughlin Clinic in Boise, Idaho. Our clinic is a specialty clinic and we treat people with foot and ankle issues. One of the common deformities that we see is a Pes Planus deformity, otherwise known as a flat foot deformity. What is a Pes Planus deformity? Well, we have a lot of people who have flat feet, and most people don't hurt at all. This is called a constitutional flat foot deformity, which is non-pathologic, which does not require treatment. And then we have people who have an acquired flat foot deformity, which becomes painful. And this is what we commonly see in our clinic. It's an adult acquired flat foot deformity. And when we see people with this, something physiologic has changed to create pain. This is an example of someone with an adult acquired flat foot who has extremely flat foot and a painful midfoot arthritis. Now, the cause of an acquired Pes Planus deformity includes a dysfunction of the main tendon on the inside part of the foot, called the posterior tibial tendon. That's represented by this red cord on the inside part of the foot. And as you could see in our model, this tendon has torn here before it inserts on the foot. The second thing that we see commonly is a rupture of the ligament right underneath that, which supports the talar head and the navicular. That's called the spring ligament. We often notice deformities and injuries in both the tendon and the ligament. Now, what we also know is that the posterior tibial tendon is a very active muscle tendon unit that keeps the arch intact. It's the spring ligament underneath that's a static mode of support that keeps the bones together, and they work in concert to keep an arch high. What you see here is a Harris mat imprint. On your left-hand side, that's a normal appearing foot with a little bit of an arch built in, and then on your right is someone with a Pes Planus deformity in which the arch has collapsed. Now, it was in 1936 that Kalowski first described inflammation of this tendon unit, and then in 1953, it was Key who identified that some people will rupture the posterior tibial tendon, as you see in this image. And it was relatively recently, in 1974, that Dr. Leonard Goldner first performed a tendon transfer surgery for a disease of the posterior tibial tendon with a flat foot deformity. All of this history has suggested that conservative treatment often will get worse and that surgical treatment can be better. The causes of a flat foot deformity can include a fracture of the midfoot, as you see in this x-ray, or a tear of the posterior tibial tendon and or the spring ligament, as you see in this MRI scan. Arthritis of the midfoot can also cause a collapse of the arch, leading to a flat foot deformity. Lastly, we commonly see people with diabetes in our clinic who have neuropathy, and they don't have good feeling of their foot or their skin. Some of them will go on to develop a Charcot midfoot breakdown, and that will cause a loss of someone's arch. In this x-ray, you see someone whose midfoot bones have completely dissolved due to multiple fractures, and this person came in with an extremely flat foot because there was no rigid support in their foot at all. Those that have been exposed to steroids or who have diabetes also have a higher incidence of a Pes Planus deformity. If you look at someone from the front, due to a long-standing flat foot deformity, we'll often see what we call a forefoot supination or Varus deformity. And what that means is that if you hold someone's ankle straight up and down, their toes are angled so that the big toe is actually higher than the baby toe. And then we'll often see people who cannot perform a single limb heel raise test. This correlates with a tear of the posterior tibial tendon. We'll often see people who have pain along the course of the posterior tibial tendon, and when this occurs, people will often limp. Now, when you come to our clinic, a workup will require x-rays, which are weight-bearing ones, and we often see this loss of the longitudinal arch. So the line between the talus bone and the first metatarsal is no longer collinear and the arch has collapsed. And then from the top, the forefoot has moved off to the side to the point where this talus bone, where you see that yellow arrow, is uncovered by the navicular bone over the top of it. Sometimes we'll order an MRI scan. This is an expensive test, but it will often show the soft tissue derangements, such as this person. The arrow is pointing to disease of the posterior tibial tendon. For people who have painless deformities, the treatment is often non-aggressive treatment and even no treatment. But what we like to do in our clinic is to see people back over time to make sure things aren't getting worse. We often start off conservatively with either medications, such as an anti-inflammatory medication if it's not contraindicated, or even casting with stage 1 tendinitis of the posterior tibial tendon. Sometimes we'll recommend an orthotic. These can be an over-the-counter orthotic or a custom one. The custom one is a custom mold to the bottom of your foot, but the idea is to create an arch to support an insufficient posterior tibial tendon. Sometimes we'll prescribe a brace such as this, which will give further stability to the foot in the setting of disease of the posterior tibial tendon. We'll often tailor your treatment based on the stage of deformity. So for stage 1, we'll often recommend either a cast or an orthotic or a brace. For stage 2, this requires more solid support, such as this AFO. And for stage 3, we'll often move to a double upright rigid brace, which is incorporated into a shoe to support the more severe rigid deformity. Now, if someone fails conservative treatment and they're a candidate for surgery, the last option is surgical intervention. For stage 1, we'll often perform a tenosynovectomy, which means opening up the diseased tendon sheath and debriding the inflamed tissue around it, and then repairing any small tears that may be present in the tendon. The results of stage 1 treatment are quite good. Teasdale and Johnson noted complete relief in 74% of their patient cohort. For stage 2, what has become the gold standard is to perform a tendon transfer using a tendon next door to the posterior tibial tendon. This is a tendon called the flexor digitorum longus tendon that we'll use as a substitute of the diseased tendon, and we'll dock it into the same navicular bone where the posterior tibial tendon inserted originally. This goes hand in hand with a cut to your heel bone called the calcaneus, and will often slide the heel bone toward the inside. The reason for this goes back to 1935, and it was Cotton who realized that if our weight-bearing axis is centered between the heel, the 5th metatarsal head, and the 1st metatarsal head, that people do quite well. So we strive to get that weight-bearing axis within this triangle, and moving someone's heel to the inside will often accomplish this. Now, some people will still have this forefoot Varus deformity. So it was Jeff Johnson and myself that repopularized the cotton osteotomy, and what we'll do is we'll take a wedge of bone and put it into the first ray to bring it down so that the ball of the foot is perpendicular to the long axis of the tibia. The results of stage 2 surgery appear to be quite good. Our colleagues in England looked at a 15-year follow-up for the FDL tendon transfer and the calcaneal osteotomy. And what they found is that 87% of patients were free of pain and functioning well. The surgical treatment for stage 3 is a little bit different. Because the hindfoot is diseased and rigid, we'll often move to a hindfoot fusion involving this joint here, the subtalar joint, and sometimes this transverse tarsal joint here. That would require a subtalar joint fusion in which the joint is obliterated, or a triple fusion including the subtalar joint and the transverse tarsal joint to maintain the posture of a plantigrade foot. We consider a triple hindfoot arthrodesis a salvage procedure, and so this is considered very carefully before embarking on such a procedure. With stage 4, this will often require an ankle fusion, or what we call a tibio-talocalcaneal fusion, with this hindfoot fusion nail that you see in this image. In conclusion, we know that posterior tibial tendon dysfunction is linked with a Pes Planus flat foot deformity. and that conservative treatment can work for some inactive individuals. But we also know that surgical treatment has a good track record for many stages of the disease. Here in the clinic, we feel that it's very important that your questions be answered by the physician team that you choose to see. In conclusion, posterior tibial tendon dysfunction is linked with a Pes Planus deformity. We know that conservative treatment can help some people, especially if they're inactive. We also know that surgical treatment has a good track record when the disease is caught early. Here in the Coughlin Clinic, we feel it's our responsibility to help you. Both myself, Dr. Coughlin, and Dr. Flint, we're here to answer your questions. Thank you.